Welcome and thank you for standing by. All participants are in a listen-only mode. Today's call is being recorded. If you have any objections, you may disconnect at this time. My name is Lisa Wagner, and I am on the policy team at the National Center for Health Statistics, or NCHS. I am pleased to introduce today's speakers, Dr. Lara Akimbami and Dr. Brian Stearman. Lara is a pediatrician and medical officer with the Division of Health and Nutrition Examination Surveys at NCHS. Her research has focused on childhood asthma and allergies and health disparities. Brian is an epidemic intelligence service officer assigned to the Division of Health and Nutrition Examination Surveys. He is a pediatrician and medical officer specializing in environmental health and has authored several reports using National Health and Nutrition Examination Survey, or NHANES data. Jay Clark will join Lara and Brian during the Q&A session. Jay is a senior statistician at Westat with more than 20 years of experience in the statistical aspects of survey research and data quality control. He has worked on sampling and weighting tasks for NHANES for more than 15 years and currently oversees the daily statistical activities to assist DHANES with this study. Lara and Brian will present on the newly released data set from NHANES from 2017 to March 2020. This data set provides nationally representative estimates on selected health outcomes prior to the COVID-19 pandemic. The presentation will be followed by a question and answer session. Just a reminder, the audience is currently in a listen-only mode. Questions or comments may be entered through the Q&A feature, and we will address them as time permits during the Q&A session. And now I turn it over to Lara.
Thank you, Lisa, for that introduction, and good afternoon, everyone, and thank you for joining. In this webinar, we will discuss how the COVID-19 pandemic affected data collection for the National Health and Nutrition Examination Survey, also known as NHANES. We will provide an overview of how a public release file was prepared with data from 2017 through March 2020. We will also present estimates for prevalent health conditions that were calculated using these data. First, we'll start with a brief overview of NHANES. NHANES is designed to assess the health and nutritional status of adults and children in the United States. It is a complex survey in two ways. First, it uses complex sampling design to ensure that the data collected are nationally representative. And second, it combines information collected across several different survey components. During a home interview, participants provide information on demographic characteristics, health conditions, and risk factors and behaviors, such as which dietary supplements and prescription medications they are using, as shown here. Then participants are invited to travel to a nearby mobile examination center to participate in a health exam, undergo tests, provide lab specimens, and take part in additional interviews. After the exam, participants may be contacted again to participate in post-exam content. This can involve activities such as dietary recall interviews or wearing a physical activity monitor. The survey content varies over time and covers a wide variety of health conditions and public health topics. Conducting examinations along with health interviews provides data that is invaluable for public health, but it also poses operational and statistical challenges. NHANES is conducted in 15 sites per year due to the intricate field operations of the survey. The mobile exam centers, or MECs, must be driven to each new site and set up and maintained according to exact specifications. Teams that include interviewers, clinicians, technicians, and engineers live in the field full-time as they travel among the different survey locations over the year. Each MEC contains a mobile laboratory with all the equipment needed for specimen processing and storage until specimens can be shipped to laboratories for testing. On-site testing is also performed for some health measures to provide immediate results to participants. There's also other equipment for medical testing in the MECs, For example, a spirometer has been used to measure lung function, and a sound isolating room is used to test hearing. Depending on which health exams and measures are being performed, equipment can be swapped in and out of the MECs. The range of pre-pandemic activities that occurred in the MECs was broad. These included body measures such as weight and height, blood pressure measurements, DEXA scans to assess bone density, oral health exams, and phlebotomy and urine collection to collect specimens for a wide array of lab tests. In addition, participants responded to additional interviews, such as audio computer-assisted self-interviews for more sensitive topics that included reproductive health and alcohol and substance use. The MECs provide a way to standardize protocols, equipment, and exam environments across different locations and across time so that results are comparable. This allows for more accurate interpretation of health differences between groups and of trends over time. NHANES began continuous field operations in 1999. And although data collection continued from year to year, data were released in 2-year cycles. An example of the 2017 to 2018 data cycle release on the NHANES website is shown here. Each 2-year cycle is drawn from a multi-year sample design. These sample designs have changed over time to keep up with changes in the US population. For instance, the 2015 to 2018 sample design selected 60 locations to be visited over 4 years. The 2015 to 2016 data collection cycle visited the other 30. Although data are available for 2-year cycles, NHANES advises combining cycles together into 4-year data sets to calculate reliable estimates for subgroups. For example, estimating the prevalence of a health condition by age group separately for men and women, or for race and Hispanic origin groups among children, is best done with a 4-year data set. So like almost everything else, NHANES was affected by the COVID-19 pandemic. The 2019 to 2022 sample design also chose 60 locations to be sampled over 4 years. NHANES entered the field in 2019 with a plan of visiting the first 30 locations in the 2019 to 2020 data collection cycle. In March 2020, that is, a growing number of cases of COVID-19 disease were being reported to CDC. This suggested that community spread was occurring. Widespread shutdowns had not yet occurred, but the environment was starting to change. For example, this mobility data showed that during March, normal patterns in movement started to decline. The NHANES program needed to decide whether continuing field operations posed a risk of coronavirus transmission to participants and staff and their close contacts. On March 16th, field operations for NHANES were suspended. And although it wasn't clear at the time, this meant that the 30 locations planned for the 2019 to 2020 cycle would not all be visited. When field operations were stopped in March of 2020, the survey had been to 18 of 30 planned locations. And as 2020 progressed, it was clear that there was no feasible way to resume in-person exams. The potentially long pause before field operations could be resumed raised questions about how a break in data collection would affect estimates of health conditions. Resuming data collection when it was safe to do so would mix pre-pandemic data and pandemic data together and potentially introduce bias into the estimates, especially for a 2-year cycle that would have to be extended. Therefore, it was decided not to collect more data for this cycle. Because no additional data would be collected, the 2019 to March 2020 sample was not nationally representative. There was no method to create sample weights using the 2019 to 2022 sample design. Additionally, publicly releasing the data for fewer than 30 locations could pose disclosure risk for participants. However, the data that were collected represented a significant investment by survey participants, the federal government, and collaborators, and simply not using the data wasn't an option. So a solution was found in the creation of a pre-pandemic data file. The 2017 to 2018 two-year cycle contained a complete sample and was nationally representative. It could be used to build a larger data set, and methodology to combine a probability sample with a non-probability sample was used, but adapted to this situation. The probability sample in this case was the 2017 to 2018 sample. And rather than a non-probability sample, the 2019 to March 2020 sample was a partial probability sample because it was selected based on the 2019 to 2022 sample design. So here's an overview of how a 2017 to March 2020 pre-pandemic dataset was created and some analytic considerations when working with the data. In this slide, I've highlighted the sample design years in colored font to distinguish these 4-year sample designs from the 2-year data collection cycles. The 2015 to 2018 sample design specified the locations chosen for the 2017 to 2018 data collection cycle. And as we mentioned previously, all 30 locations were visited in 2017 to 2018. The 2019 to 2022 sample design specified 30 locations that were supposed to have been visited in the 2019 to 2020 data collection cycle, and only 18 were visited. Combining the 2017 to 2018 sample with the 2019 to March 2020 sample posed a problem. The 2015 to 2018 and the 2019 to 2022 sample designs were different because the 2019 to 2022 sample design was updated to reflect the changing United States. So the chosen solution was to pick one of these sample designs. Because the 2017 to 2018 data collection cycle fully adhered to the 2015 to 2018 sample design, this design was chosen. The 18 sites that were visited in 2019 to March 2020 were reassigned to the 2015 to 2018 sample design. Now that a design was chosen, the sample weights could be calculated. However, there were still some issues that needed to be resolved. The 2019 to March 2020 locations didn't line up exactly with the 2015 to 2018 sample design. The result was that some portions of the country were underrepresented in the data. An adjustment factor was used to equalize representation over the sites visited from 2017 to March 2020. And once that was done, interview weights and exam weights were then calculated using previous methodology. Extensive assessments confirmed that the final sample was nationally representative by making demographic comparisons to the American Community Survey, which is a population survey administered by the US Census. So here are some analytic considerations for using these data. The resulting 2017 to March 2020 pre-pandemic data can be used to calculate nationally representative estimates of health conditions and behaviors. It can be used like the previously released data sets for 2-year cycles. However, the data from the partial 2019 to March 2020 cycle by themselves are not nationally representative. Therefore, 2019 to 2018 data, 2017 to 2018 data cannot be compared to the 2019 to March 2020 data. And remember that because the 2019 to March 2020 data did not conform to the 2019 to 2020 survey design, no separate survey weights could be constructed for this cycle. It is not appropriate to use the 2017 to March 2020 pre-pandemic weights for the partial sample collected in 2019 to March 2020. The weight adjustment that was applied to the 2017 to March 2020 data was designed for overall estimates, but not necessarily for subgroups. So therefore, when 2017 to March 2020 estimates for subgroups are compared to earlier estimates, trends should be interpreted with caution. For example, when the adjustment factor and other measures were applied to the survey weights, national representation by sex was achieved, and so was representation by age. But some sex-specific age groups, for example, may have larger variation in estimates depending on how the participants are distributed across survey locations. The 2017 to March 2020 dataset represents a 3.2-year sample rather than a 2-year sample. This means that sample sizes are larger than for 2-year samples, and that standard errors for estimates are generally smaller than those calculated for 2 datasets. In other words, estimates made with a 3.2-year sample will generally be more precise than those from a 2-year sample. Conversely, standard errors for the 3.2-year 2017 to March 2020 dataset will likely be larger than for 4-year datasets made by combining previous 2-year cycles. So speaking of combining data cycles together, analysts may wish to do this with the 2017 to March 2020 data in certain circumstances, such as when assessing a less common health condition or when analyzing subgroups with smaller sample sizes. Previous analytic guidelines had formulas to use to apply to the survey weights when combining cycles. Adjusting the weights to account for the different time period for the 2017 to March 2020 cycle is necessary when combining these data with prior 2-year cycles. So for example, when the 2015 to 2016 2-year cycle is combined with 2017 to March 2020 3.2-year data, this data set represents a 5.2-year period when combined. Therefore, analysts would want to use a multiplier for sample weights for each cycle. This should be the fraction represented by each cycle of the average annual population of the entire 5.2-year period. Or another way to think about it is that one would be calculating the population in the middle year of the period. For 2015 to 2016 sample weights, the multiplier would be the fraction 2 over 5.2. And for 2017 to March 2020 sample weights, it would be the fraction 3.2 over 5.2. Likewise, combining 3 successive cycles would represent a 7.2-year period. The multipliers for the survey weights for each cycle are shown here. And note that in each case, the numerators for the multipliers across the cycles add up to the duration of the entire period. Analysts also need to keep in mind some issues involved in combining cycles together. One major consideration is if the condition being analyzed has changing prevalence over the time period being assessed. Combining cycles together would mask any trend over the period. Analysts also need to check if the variables being assessed remain the same over successive cycles by consulting the survey documentation for each cycle. So here's a brief overview of how to access the data. The 2017 to March 2020 pre-pandemic data will be released in stages, just as done in prior cycles. Components with currently available data have active links. Components that have not yet been released are indicated with hatching. And clicking on any of the live components on the NHANES website will show the currently available data files. So here's the current list of data files that are available for downloading. These include the demographic file, questionnaire data on blood pressure, diabetes, oral health, and examination and lab data related to measuring these conditions, as well as weight status. Again, these files can be used like those from previously released 2-year data cycles. Information about using the data is also provided. Currently, there's a brief overview with analytic guidance that was posted with the data when it was released at the end of May. A longer, more detailed report will be released later in 2021, and a report presenting estimates of selected health conditions was released earlier this week. These resources are both available using the first 2 links under the highlighted section using the data that is on the data release page. So here's a glimpse of the brief report and the direct link at which it is available. And now I will hand over the presentation to Dr. Brian Stearman, who will present an overview of the recently published report on health estimates from this data set.
Thank you, Lara. We present here prevalence estimates for several selected health outcomes, calculated from the available NHANES 2017 through March 2020 pre-pandemic dataset. Next slide, please. These estimates are available in more detail in the National Health Statistics Report that was released this week and that is available on the NCHS website. Next slide. The health outcomes selected for estimates include, for children, obesity and dental caries; for adults, hypertension, obesity, severe obesity, and diabetes; and for older adults, complete tooth loss. These health outcomes were selected for estimates because they were able to be calculated from the files currently released publicly and available on the NHANES website. Next slide. Today, we present estimates by several covariates, including sex, age groups, race and Hispanic origin, and family income. Other covariates and stratification by sex are included in the accompanying National Health Statistics Report publication. Next slide. As is usual with NHANES analyses, to calculate these estimates, we accounted for the complex multi-stage probability design of NHANES, including the unequal probability of selection. Provided sample weights were used for calculations. For estimates for diabetes, fasting sample weights were used. For all other estimates, examination sample weights were used. Standard errors were estimated using Taylor series linearization, and adult estimates were directly age adjusted to the 2000 projected US Census population. Next slide. As would be expected, the overall estimates for each health outcome calculated for 2017 through March 2020 are similar to those from 2017 through 2018 alone. This reflects both the methodological adjustments as well as the patterns in the prevalence estimates, which typically are not expected to vary by large amounts from one year to the next in NHANES, due to the relatively small sample size in a 1-year data collection. Next slide. The data from 2017 through March 2020 provide an increase in sample size, generally about 1.5 to 2 times the sample size of that from 2017 through 2018 alone. Next slide. As expected, this increase in sample size generally leads to smaller standard errors, as can be seen with all health outcomes here except for complete tooth loss. However, for some estimates and some demographic subgroups, increased variation in the sampling weights, increased variation in the true underlying population values of the health outcomes from the data added from 2019 through March 2020, or both, may result in equivalent or increased variance of estimates, as seen here with complete tooth loss, which has equivalent standard errors from both time periods. Next slide. We found that 19.7% of children aged 2 through 19 years had obesity, defined as a body mass index greater than or equal to the 95th percentile for age and sex. There was no difference in obesity by sex. Obesity increased with increasing age groups. The highest prevalence of obesity was among non-Hispanic Black and Hispanic children, while non-Hispanic Asian children had a lower prevalence of obesity than other race and Hispanic origin groups. Obesity decreased with increasing family income. Next slide. Dental caries in childhood was defined here as untreated or restored dental caries in one or more primary or permanent teeth. 46% of children aged 2 through 19 had dental caries. There was no difference in dental caries by sex. Dental caries increased with increasing age groups. Hispanic children had the highest prevalence of dental caries among children. And dental caries decreased with increasing family income. Next slide. For hypertension, the estimates are based on a different methodology than those previously published for NHANES. Prior NHANES hypertension estimates have used an auscultatory protocol for blood pressure measurements. During 2017 through 2018, both an auscultatory protocol, which utilizes a manually obtained blood pressure with a mercury sphygmomanometer, and an oscillometric protocol, which utilizes an automated machine to obtain blood pressure, were used. However, during 2019 through March 2020, only an oscillometric protocol was used. Therefore, blood pressure measurements and hypertension estimates for the combined 2017 through March 2020 pre-pandemic data required the use of the oscillometric protocol. The differences in these protocols and a comparison of the blood pressure values from each protocol are available in a separate Series 2 report from NCHS. Next slide. We define hypertension here as meeting any of the following three conditions: a mean systolic blood pressure of greater than or equal to 130 millimeters of mercury, a mean diastolic blood pressure of greater than or equal to 80 millimeters of mercury, or taking a medication to lower blood pressure. Again, the blood pressure measurements were taken using an oscillometric protocol. During 2017 through March 2020, 45.1% of adults had hypertension. More men had hypertension than women. Hypertension increased with increasing age. And non-Hispanic Black adults had a higher prevalence of hypertension than other race and Hispanic origin groups. Next slide. We found that 41.9% of adults had obesity, defined as a body mass index greater than or equal to 30 kilograms per meter squared. There was no difference in obesity by sex or by age. Non-Hispanic Black adults had the highest prevalence of obesity. Non-Hispanic Asian adults had a lower prevalence of obesity than other race and Hispanic origin groups. Next slide. Severe obesity was defined here as a body mass index of greater than or equal to 40 kilograms per meter squared. During 2017 through March 2020, 9.2% of adults had severe obesity. More women had severe obesity than men. Severe obesity was less common in those aged 60 and above compared to those aged 20 through 39 and those aged 40 through 59. The prevalence of severe obesity was highest among non-Hispanic Black adults and lowest among non-Hispanic Asian adults. Severe obesity was lowest among those with a family income of greater than 350% of the federal poverty level. Next slide. Diabetes was defined here as having previously been given a diagnosis of diabetes, having a fasting plasma glucose of greater than or equal to 126 milligrams per deciliter, or having a hemoglobin A1C greater than or equal to 6.5%. Fasting sample weights were used to calculate these estimates. 14.8% of adults had diabetes. The prevalence of diabetes was higher among men than women. The prevalence of diabetes increased with increasing age, but decreased with increasing family income. And the prevalence of diabetes was lower in non-Hispanic white adults compared to other race and Hispanic origin groups. Next slide. Complete tooth loss among adults aged 65 years and older was defined here as having no natural tooth, dental root fragment, nor implanted tooth, and was based on 28 teeth, excluding third molars. The prevalence of complete tooth loss was 13.8%. The prevalence did not differ by sex, but did increase with age. Tooth loss was higher among non-Hispanic Black adults than non-Hispanic white adults, but otherwise did not differ by race and Hispanic origin. And tooth loss decreased with increasing family income. Next slide. So with regards to the future, more data releases are anticipated. These data releases will occur in several different forms. Other combined 2017 through March 2020 pre-pandemic data are expected to be released on the NHANES website and would be treated like a probability sample. The provided sample weights should be used for analyses with these data. Next slide. In the future, this data would be released on the NHANES website along with the currently available data, which can be found under the NHANES 2017 through March 2020 pre-pandemic data page. Next slide. In some cases, 2017 through March 2020 pre-pandemic data determined to have disclosure risk will be released through the NCHS Research Data Center to ensure additional measures to protect confidentiality. For these data, which are treated like a probability sample, the provided sample weights should also be used for analyses. Next slide. For those data released as limited access data files, once released, information about the variables will be available on the NHANES website under limited access files under the 2017 through March 2020 pre-pandemic data page. However, the actual data will only be available through NCHS's Research Data Center. Next slide. There are some measures that are unique to the 2019 through March 2020 NHANES data collection. These cannot be combined with 2017 through 2018. And for these measures, nationally representative estimates are not possible. These data will instead be released as a convenience tool through the NCHS Research Data Center. Next slide. For these data released as limited access data files, once released, information about the variables will be available on the NHANES website under limited access files under the 2019 through 2020 data page. However, again, the actual data will only be available through NCHS's Research Data Center. Next slide. And this can be found on the NCHS website. Information about accessing restricted data, including submission of research proposals, can be found here. Next slide. Thank you.
We are now entering the question and answer session. As time allows, the presenters will address questions from the Q&A feature. Please submit your questions through the Q&A feature now. If your question or comment is not addressed, please direct it to paoquery@cdc.gov. That's paoquery@cdc.gov. Okay. So we definitely have some questions. One question is, will all measures collected be released? For example, will the dietary data eventually be released?
I can take that question. Yes, we plan to definitely release all data. It will be in stages as the data are processed and evaluated, kind of pretty much similar to the schedules used for previous cycles. When they are released, they'll be under the What's New section of our webpage, and we anticipate the next data release to be towards the end of the summer.
Great. We have another question on the poverty level. How many participants had missing values of FPL? Is an imputation approach required for analyzing the FPL?
Yes, so that's a good question. I can take that one. So not all participants had their federal poverty level necessarily available, though it was a very high percentage. I don't have the exact number available right now. The sample sizes that we had for these estimates are available on the NCHS National Health Statistics report that I was referring to earlier. And I believe I'd have to double check the exact percentages, but I think that we had a high enough percentage, and it's pretty close to complete, that we didn't think that imputation was necessary here. Yeah.
Okay. Great. We have another question about restarting NHANES. So do you all have any additional information around when the NHANES will restart?
Yes, we're very excited that we'll be restarting operations this summer. So we plan to, we're actively planning and preparing to return to the field just in a couple of weeks, and hopefully we will have smooth sailing to the end of the cycle this time.
Great. We have one question about obesity, the obesity measures. I think, Brian, you referred to particularly, the question is, could you show the slide with the findings again on the 2017 to 2018, or the 2017 to March 2020 findings? So I don't know, Laura, if you can do that, or if you guys can recount those particular measures or findings. And then that, I think this had the same question on when we would be restarting. Would it be a 2021 to 2022 data set?
Sorry, I was trying to unmute myself there. Can you all see this slide now with the obesity estimates? Okay. Yes. So this was for adult obesity, again, greater than or equal to 20 years. That's a body mass index of greater than or equal to 30 kilograms per meter squared. So showing it here, but again, for people who want to be able to look at any of these slides or want to see the estimates in even more detail, there is a National Health Statistics report, which I can show again the link to a little bit later, easily found on the NCHS website or on the NHANES website. There's a link to it as well. It has all of these estimates plus more.
And then the second part of that question was around the data set. So once we restart NHANES, will we be considering that the 2021 to 2022 data set, or is there still discussions about that?
That would definitely be considered 21 to 22 data set. So we anticipate release of that with the normal schedule that we have for production after data processing.
Okay. And the question also, could you go back to the previous slide?
So here's one for hypertension, which was the previous slide.
It says with all the measures, obesity, adult diabetes.
Okay. Yes.
Yeah.
I can go back. That is several slides previous. Here are the estimates for each of the measures. I'll just kind of highlight it a little bit more. So in orange, what you can see here is the 2017 through March 2020 pre-pandemic estimates. And for comparison's sake, in blue, we provide the 2017 through 2018 alone estimates. So just to kind of as a reminder, the 2017 through March 2020 contains the same participants as 2017 through 2018, along with those that were enrolled in 2019 through March of 2020. So they are not independent samples.
All right. We have another question here on trend testing for several of your sample designs. So the question is, could you please clarify your recommendations regarding trend testing for 1999 to 2002, 2003 to 2006, et cetera, 2013 to 2016, and then 2017 to March 2020?
Yeah, that's a great question. We have analytic guidelines on our webpage that covers some of those questions specific to NHANES, as well as a general NCHS trend report that has recommendations on analyzing trends of our data. The thing that you need to take into account when looking at the 17 to 20 data is that it's a 3.2-year period as opposed to a 2-year period. And therefore, the time points would be unequally spaced across those data points. So you would need to use some indicator in your model of the midpoint of each data period. So one way we do it is to take the the time period and divide it by 2, and then add that to the beginning of the time period. So for example, if you were doing a trend from, say, 2013 to 2020, the first time period would be 2014, then the next would be 2016, and then the next for the 3.2-year cycle would be 2018.6. I think that's right. And that would allow your model to know that those data are coming from unequally spaced periods in time. For the weighting, again, the previous weighting recommendations are in our analytic guidelines, and I refer you to those because it's a little difficult to relay all of those multipliers for the sample weights. But the ones that we presented today here, we'll make sure we release those on our website soon, so you have those for reference. And I believe this recording will also be available for that.
Great. Great. We have a question regarding weights again. So the question is, when calculating weights for combined data sets, so for example, between the 2015 to 2016 with the 2017 to March 2020, you indicated that the weight for the 2015 to 2016 cycle should be the 2 divided by 5.2. And for 2017 to March 2020 should be 3.2 divided by 5.2. So the question is, does that mean when coding for the new weight, it would be done differently within the same combined data set for data from the individual cycles? Does that make sense?
I'm not sure, but I guess the way I would approach that is to combine the data and then to multiply the weights and then to do any estimates from your combined data set. So you would subset. So for example, if you're interested in just the 15-16, you would subset that sample when you're looking at that estimate, but use the entire combined data set. I know, Jay, do you have another take on that question? I'm not sure I interpret it completely correctly.
I think you answered it fine. I mean, the main thing is just that instead of 2-year cycles, now before each data set was for 2 years, this new one for 2017 to March 2020 is for 3.2 years. So you just have to make the appropriate adjustment. And I think it is spelled out more clearly in the analytic guidelines.
Right. So we have another question. The question starts with a statement. You said with some of the measures, the 2019 to 2020 findings could not be merged with the 2017 to 2018 findings. Could you give an example or examples of which measures those were?
So those measured would include things that were newly introduced in 2019 to 2020 that wouldn't have any counterpart in 17-18. And I think some of them might be nutrition for 0 to 2-year-old children. That may have started in, I have to go look to make sure I'm getting this right. But for example, there would not be a 17-18 variable to combine those data with. So we can only release the data that were consistently measured in the 17-18 cycle and the 19-20 March 2020 cycle.
We have another question on what impacts could this combined file have on data linkage or analyses using linked files?
So that's a great question. We are definitely in conversation with the linkage group at NCHS. And we anticipate that the linkage would continue pretty much the same way as for other files. Again, we would probably do linkage for the 17 March 2020 file to protect confidentiality and to make the linkages more robust.
We have a question as well. Are you all thinking about how the next iteration of NHANES might incorporate any COVID-19 related data?
Yes, it's a different survey than, say, real-time surveillance, but it's when you combine those COVID data potentially with all the rich data we have. It's a very powerful data set. We're asking about immunization as well as serostatus. So we're collecting serology data, both to indicate whether you were naturally or participants were naturally infected versus obtaining antibodies through vaccination.
Okay. So I think this might be a follow-up to the trend analysis question. Can we use a regression to model an outcome by 2-year periods plus the 2019 to March 2020 period as a continuous variable?
Yes, and in that case, you would use kind of the midpoint of the time period that I was talking about earlier. So, for example, if you started with 2013 to 2014, the mid-year of that would be 2014 when you round up. The mid-year of 15 to 16 would be 2016, and then the mid-year of 17 to March 2020 would be 2018.6. So those are the values you would put in your regression, but you could also just start with 1 if you wanted to, just as long as those have the same spacing as the years. You could use essentially any number you wanted to represent the data points in time.
Okay. We have a follow-up question from the COVID-19 related question. So are the samples that were collected in Q4 2019 and Q1 2020 being checked for any antibodies or other markers of COVID-19 exposure?
That's a great question. We have not checked those data because, as I mentioned before, we're a very clustered survey. So the places that we were, just because it's a partial sample in an entire sample design, would not be nationally representative. So it would be difficult to interpret how to use those estimates if we were to check those data. So while we have stored samples and would be able to do that in the future, if it looks like it would reveal some useful public health data, we haven't undertaken that yet.
Okay. Another question, can you compute subnational estimates with these data?
That's a question we get frequently, and unfortunately is very difficult because of our design. In order to examine enough people, we're limited into how many places we can visit per year, because you have to have to stay in one area long enough for people to be interviewed and then to travel to the MEC to get examined. That means you have very sparse data per year, and we don't visit the same places every year. So it would be difficult to be able to combine enough cycles for any one place to get a subnational estimate. The exception is LA County, which is so large that it is usually included in our sample. And we do have data from that county available as limited release data. You can find that on our website. But that is the only example really where we're able to go subnational.
We have a question about how can the public best know what happened throughout most of 2020 and early 2021 in terms of trends regarding the US obesity, diabetes, hypertension, and other measures, because there will be no NHANES data for that period. Should or can people look to other surveys like the National Health Interview Survey for some of those data? I would say yes.
Brian, I can chime in, and then Brian, you can chime in on top of me. So for yes, there are other surveys that release those data based on self-report, and there are some good studies out there that show how self-report measures of basically BMI calculated from self-report measures differed from measured values. So in general, people tend to overestimate their height and underestimate their weight. It would be like squeezing your Zoom picture in a little bit. So there's a lot of literature about adjustment equations and those type of methods that you could use to adjust for the mode effect of people measured versus self-reporting their weight and height. But the Health Interview Survey collects those data. The Behavioral Risk Factor, BRFSS, Behavioral Risk Factor Surveillance Survey, also collect those data. And those are both available at CDC.
Great.
I don't really have much else to add. I think you answered that question well. Yeah, some of those are NCHS surveys, and some of them you can be found through, for instance, for obesity, going to the obesity website on CDC. They have a lot of linkage to different surveys that they use to come up with estimates as well.
Great. So we have a question now, a couple of questions regarding the restart of the survey, or I guess the planned restart of the survey. Are there general concerns with the program around restarting, particularly with response rates? And are there any sort of plans to address that? And then I guess the second part of that question that might help with this is, I guess, what sort of precautions are being taken into consideration as you're restarting?
Yeah, great questions, and ones that concerned us greatly through the past year. So it's true that the response rates for NHANES, as well as all federal surveys, have been declining since about 2011. And it is a concerted effort across federal statistical agencies to understand and address those falling response rates. Because as we know, when you have a lower response rate that's believed to possibly impact the data quality. We did an extensive evaluation of the 2017 to 2018 data of how non-response affected our estimates. And that report is also available on our website. We used all of those methods developed to really assess and address bias with the 2017 to March 2020 weighting as well. When we go back into the field, we are really looking to all the various methods to really interest people in responding to the survey to increase response rates. And we're trying many different things together. Part of that is, as the second part of the question alluded to, is ensuring that participants they can safely participate. So when they visit the mobile examination center, there is a screening protocol in place. There's information about that on our website as well for participants. If anyone listening happens to be chosen, you can get that information there. It's very similar to what's being done in medical centers, including the same type of precautions with full masking while you're in the MEC.
Great.
You know, Jade, was there any other aspects that you're aware of that I didn't mention?
I think you covered it really well.
Great. For Brian's a question, how do hypertension estimates differ with the two new protocols, the two protocols, and the oscillometric one and the auscultatory, the new one being used?
That's very helpful. Excellent question. So I'd say for the most comprehensive answer, I would refer the person who asked the question to there's an NCHS Series 2 report by Eschega et al., which is entitled Comparing Blood Pressure Values Obtained by Two Different Protocols, and it was released in April of this year. The report compares the two blood pressure protocols during 2017 through 2018, when they were both taken among the same participants. And briefly, the mean systolic and diastolic blood pressures did differ a little bit, with higher mean systolic blood pressure and lower mean diastolic blood pressure using the auscultatory protocol compared to the oscillometric protocol. However, the prevalence of stage 1 hypertension, which is what we showed here, did not really differ significantly between the two protocols, and there was generally good agreement between those two protocols. Just to give a little bit more of a background on these two different measurement protocols, I think something that can be a little bit helpful is to, I touched on it a little bit, but the auscultatory protocol uses mercury sphygmomanometers and was taken with clinicians or physicians, whereas the oscillometric blood pressure protocol use automated devices and are done with health technicians. So there were some minor differences in the actual protocol, as well as the differences in the equipment that were being used. And some more detail on this, again, is in that Series 2 report that I've mentioned a few times now.
Great. So we have another question on the COVID-19 data, potential additions to the next iteration of NHANES. Would we get a self-reported history of COVID-19 infection as a part of that next iteration? Is that one of the considerations?
There is a COVID-19 questionnaire that goes along with the measurements, and I believe there are questions about self-reported infection to correlate with the serology data that will be collected.
Okay, great. We have no additional questions currently. Any other questions from our attendees? Please type them in the Q&A feature now. All right, I'm not seeing any. So thank you all for attending today's NCH webinar on the National Health and Nutrition Examination Survey 2017 to March 2020 pre-pandemic data release. If you have any questions or comments that were not addressed during this webinar, please email them to paoquery@cdc.gov. That's paoquery@cdc.gov. And I just want to say a special thanks to Laura, Brian, and Jay for joining us today. So thank you all.